So in the 2025 American Heart Updates, they decided not to recommend mechanical CPR, which has caused a lot of debate and discussion across the healthcare community. And the reason this is stimulating so much debate and discussion is because, at least from what we can see as healthcare providers, mechanical CPR provides what looks like high quality CPR. So, why wasn't it recommended? So, a few months before the American Heart Update, there I was, happy and content with my mechanical CPR device. I felt like it was helping me provide better care to my cardiac arrest patients. And then a friend of mine shared a letter that was written by Dr. Jeff Jarvis. And in this letter, he didn't really criticize the devices or say that they were ineffective. He was trying to make the point that there wasn't enough evidence behind it. And people like me that saw the benefits of the Lucas device when they were being used appropriately easily fell under this illusion that wasn't supported by data. It just goes to show how easy it is for us to believe something that we want to believe. And then the de emphasis of the mechanical devices in the 2025 updates left me kind of scratching my head. So I dug into the data a little bit. I was just curious about the conflict between what the recommendations were versus what I was seeing. So as I dug into it, I realized they were just falling in line with a larger group, the International Liaison Committee on Resuscitation, which is this large international group that collects data and puts out recommendations. Basically, it's the world's American heart. And when they dug into the data, it wasn't that they were finding a whole lot of bad data. They weren't finding any good data, which kind of made me feel a little bit better because I realized they didn't make this recommendation based on a bunch of negative patient outcomes. They made it based on the same thing Dr. Jarvis did, a lack of good evidence, which validated what I was seeing and inspired me and made me feel like maybe they still have a place in patient care. Now, don't get me wrong, I'm a huge fan of evidence based medicine. During the course of my career, I have watched it carry EMS out of the Stone Age. And before we embraced evidence based medicine, we did things that we thought made sense on the surface, but we're actually, granted unintentionally, we were harming patients. And then as soon as we started embracing evidence based medicine, EMS started to be more effective at saving lives. And we all became better healthcare providers for it. So I'm not against evidence based medicine, but I am conflicted because I saw this de emphasis by the American Heart Association and it contradicted what I saw in the field. Now, at my service, we use the Lucas device. I hear great things about the Zoll Life Band, but I don't have a lot of hands on experience. But I do have a lot of hands on experience with the Lucas device. So I'm going to use that as an example. When I put that on a patient, I see indications of compressions that no human can match. Instantly, the capnography levels go up. I've even had patients where their fingertips start to move a little bit or their eyes will flicker. These are all things you would never see in traditional CPR. Yeah, I did find a handful of well done studies, but unfortunately, they were just small and they were showing better outcomes with traditional CPR, but that didn't match up with what I was seeing in the field, with exception of the application of these devices. Which makes me wonder, how much role does that play in these studies? Now, if you would, zoom into an individual chest compression. If placement and depth are all right, does it matter if a human being or a mechanical device is doing that compression? Of all the studies that I went through, the only discussion on application of the mechanical devices was a concern that it may delay that first shock. Now, personally, as we've implemented this over the last few years, I've had a lot of first responders start to develop bad habits that were easily corrected with some direction. Now, aside from delaying the first shock, other things that I've seen in the field that could possibly drive this bad data is a delay in starting chest compression. And as they approach the patient, they're more focused with getting that Lucas device on. Now, the other thing I've seen is a significant drop in CCR because of the time it takes to attach these devices. So that forced us to look at other methods to get the Lucas device on quicker while minimizing breaks in chest compressions. And then lastly, placement. Not only initial placement, but continually monitoring that placement because, as you guys know, those devices will walk up the patient's chest. So they need to be constantly readjusted. So to sum up my questions, I'm assuming you guys are going to continue to use this, but how is it going to affect your patient care? If so, what do you think should change? And is there any data out there that I didn't point out that might help guide paramedics like me?